Good afternoon, everyone. This is Mrftt HIV STI Echo. This is our 75th episode, shall we say. We are 3/4 of our way to batting a century. I am Dr. Gregory Boyce. I'm your presenter this afternoon. We're a small crowd today, but that's okay. We don't mind. We will be uploading this to YouTube, so if anyone missed it in the past, they'll be able to benefit from the presentation. And we're presenting today on something called immune reconstitution syndrome or immune reconstitution inflammatory syndrome. And the reason why I chose to present it is because I realized I'd never actually done a presentation. I thought I had. And I actually found a really interesting case I'm going to share during the context of the presentation that sort of switched on the light bulb for me in terms of how we manage and how we investigate iris in Trinidad and Tobago. So I just want to acknowledge all the sponsors and supporters of today's program, and they have no potential conflicts in relation to this presentation. So let's get started. Our learning objectives today will be to describe the characteristics of an iris diagnosis, to discuss the risk factors for developing iris, and to outline the broad principles for managing a suspected case of iris. So I'm going to flip the script slightly, and we're going to actually start with the case, because I think the case illustrates what I'm going to discuss later on really, really well. So this is the case of a 30-year-old heterosexual male who actually first presented to us in about 2016, about 6 years ago. He was newly diagnosed HIV positive after developing a right T8 dermatomal herpes zoster, so shingles in the right chest. And was correctly, the astute clinicians in A&E thought, well, this is a 30-year-old, he was 24 at the time, 24-year-old with shingles, let's check for HIV. He was in fact positive. His mother was actually known to us. She was diagnosed in 2002, but it was unlikely that that he had been perinatally infected, because she would have had him tested in childhood. The patient's female partner at the time admitted that she was previously aware of her status. She was actually attending a clinic and had not told him. And it was actually, the disclosure process didn't go well. It was violent towards her. They separated. But his baseline CD4 count was actually pretty okay, 630. Baseline viral load, 34,000 or thereabouts. But at the time in 2016, we had not yet started same-day initiation of ART. So we had not offered antiretroviral therapy on the day he was seen by us. And he would have been sent home with a follow-up appointment in a few weeks. Now, he was actually lost to follow-up for about 6 years and came back just a few months ago, in April of this year. And he was actually encouraged to return to care by both his mother and a neighbor who had noticed he was looking unwell. And he had come complaining of weight loss and fatigue over the preceding several weeks, maybe a couple of months. He admitted that the reason he had been lost to follow-up was he was in denial about his status. And he was still very angry at his ex-partner for deliberately infecting him with HIV. So he didn't want to deal with it, just ignoring the fact of his status and going on with his life. But he, again, couldn't ignore the fact that he had lost 20 or 30 pounds, was feeling fatigued and unwell. When he was seen by the admitting clinician, he had oral thrush, he had the papillary eruption of HIV. CD4 count was 9. And viral load was over 300,000 copies at the time.
Wow.
But yeah, it had no other clinical signs and symptoms. He started antiretroviral therapy with a regimen of emtricitabine, tenofovir, efavirenz, commonly known as the triple, along with cotrimoxazole for pneumocystis prophylaxis. And he actually did really well. Over the next couple of months, he put on about 10 kilograms of weight. He was well adherent to medication. He has a slight intellectual deficiency, so he does require a certain amount of reinforcement and explanation, but he's done really well. So I shouldn't say early April, so I should say early July, so the beginning of this month, he began to complain of a painful swelling above the left collarbone and came back into care. And when we examined it, we found a firm, tender swelling on the left supraclavicular fossa, that's just above the left collarbone, with a small area of fluctuance, but it was not warm to touch. It seemed to be a developing cold abscess, and there was no induration and very little redness. And this was what it looked like. We took a picture of it, so you can see on the right side that sort of hollow area, how it's supposed to look like, and it said fullness on the left side, which is what he was complaining of. As I said, there was no warmth, there was no redness, no induration, a classic cold abscess, in other words. And when you examined him, there was nothing else to find. His chest was clear. He had no hepatosplenomegaly. He had no other adenopathy elsewhere. He strongly denied having any fever, any chills, any night sweats. He wasn't coughing. He had no skin rash other than the little blemishes left over from the rash he had in April. His appetite was fine. He was eating up a storm. He was putting on a lot of weight. He said his mother was complaining he's eating too much. Didn't start losing weight. He wasn't feeling ill. He was feeling quite well. We repeated his viral load and had actually gone down to about 126 copies that's over 2 months. So he had a really strong, and positive reaction to starting treatment. So the $1 million question is, what will you do next? We're trying to figure out what this thing is, and I know we don't have very many physicians in the room. Let's throw out the question. I know Dr. Edwards is here, so he knows all the answers, so I won't ask him. So I'll have to pick out, Valerie, what would you do in your experience for someone presenting like this? What would kind of workup would they get?
Okay, I'm sorry, I was just kind of like, just bear with me. I don't know what I did, and I kind of lost you there for a minute. Okay, so could you repeat your question to me?
So what will you do next? This guy who started treatment 3 months ago, CD4 count 9, high viral load, develops this swelling that looks like a cold abscess in his neck, really. And there's no other signs and symptoms. He's not ill, he's not coughing, he has nothing else to find anyway. We're just trying to investigate what this might be. What kind of...
So on our end, what we would probably do is have a full panel of blood work done to get a sense of if there's something else going on that was missed during his visit for that particular situation, and then basically just usually what we do not do anything else until you get that full panel of blood work and the results coming back before you consult with the HIV specialist, his team of ARNPs, which are the nurses or doctors who are following him, and then come to a conclusion as to what the next steps are.
Well, that's very good. And I want to kind of focus on that phrase you used to try to make sure nothing was missed, because that'll come up multiple times in the conversation that we're about to have. So we did that full panel. Everything was actually completely normal. So we went a little bit more specific to do what you said, try to see what was missed. The first thing we often think about when we get what we call cold abscess is TB in a lymph node, because they tend to present as abscesses, but most abscesses they're warm, they're really, really tender, they're red and angry looking. This one was just normal looking skin, cool, normal body temperature to touch. So the first thing we have to exclude, especially in a tropical island, is tuberculosis. So we did the tuberculosis skin test. No reaction, but that might be because he's immunocompromised. His CD4 count is 9. The chest X-ray, just in case, looked normal to look for any sort of occult disease. We actually did a sputum TB PCR because I remember we had a TB specialist visit with us many years ago, and one of the things that she hammered into us is that you can have tuberculosis with a negative TB skin test, a normal chest X-ray, no fever, no cough. So always look for tuberculosis. So we looked for it using a sputum TB PCR that's very sensitive for TB, but it was negative. I actually anesthetized the skin and put a needle in after a couple of days when it was more developed. Pulled out, it was almost the consistency of condensed milk, this really viscous yellow pus, and sent it off to the lab to look for TB, and there was no TB there. But the only hit we got was we decided to check for histoplasmosis because we were actually in the middle of a study for histoplasmosis and another fungus called Cryptococcus, which is endemic in South and Central and Latin America. And we are increasingly aware that it's also endemic in Trinidad, because even though we're English-speaking Caribbean, because we're so close to the continent, diseases are actually South American. Right? So we're seeing a lot of histoplasmosis where all the other Caribbean islands just don't. Right? So that was positive. So the presumptive diagnosis given, as you say, look for everything else and see what you find, was immune reconstitution, inflammatory syndrome due to histoplasmosis in a lymph node. And so far, that's the only location he has it. He has no other symptoms, but we're following up to make sure that, again, not missing something. Yeah. So let's talk about IRIS, immune reconstitution, inflammatory syndrome. And there are a lot of varying definitions of it, but I kind of like this one. It's either a worsening of manifestations of an existing infectious disease or an abrupt new presentation like this of a disease you didn't know was there, or an atypical presentation of a disease. And it's of an infection or tumor related to infections after persons living with HIV either start or restart antiretroviral therapy, as was in this case. And it can also occur sometimes in some non-HIV settings. So for example, persons with tuberculosis without HIV can sometimes get this paradoxical worsening of IRIS. Some persons with solid tumors as well. Persons who are on immunosuppressive treatment, for example, checkpoint inhibitors, or I think TNF-alpha antagonists. When you stop it, the immune system kind of rebounds and it's a rebound in inflammation all over the place. It is typically preceded by an increase in CD4 count or decline or sharp decline in viral load. And that implies, of course, that the persons who are at greatest risk are the persons with the lowest CD4 counts and the highest viral loads. And the decline occurs in response to treatment with antiretrovirals. And so how common is this? So it's not uncommon at all. So this is a study that was actually, it's an old study, but it was a really big meta-analysis with 50 different trials, 13,000 persons included, and the overall prevalence of immune reconstitution inflammatory syndrome overall was about 16.1%. It was highest for CMV retinitis at almost 1/3. So CMV is cytomegalovirus. It is a virus that tends to affect persons who are the most immunosuppressed with CD4 less than 50. It can affect the eye, it can affect the GI tract, it can sometimes cause a very rapidly progressive encephalitis, and IRIS occurs in almost 1/3 of persons who are diagnosed with that. Cryptococcal meningitis, again, 1 in 5, again, a condition that tends to affect the most immunocompromised person living with HIV. Tuberculosis, about 15%. Progressive multifocal leukoencephalopathy, which is due to brain infection by something called JC virus, 16.7%. Thankfully, we don't see PML very much anymore because there is no good treatment for it, and it tends to be progressive and fatal in a significant number of cases. And Kaposi sarcoma, which we didn't see for a long time, started to see every couple of cases now and again, particularly in men who have sex with men. The rate of IRIS is about 6.4%. We actually had a case I presented to Dr. Edwards of a young man who got classic Kaposi sarcoma IRIS and was really, really more ill after starting treatment rather than less ill, because he had inflammatory reactions after starting antiretroviral therapy. Thankfully, IRIS is not often fatal. Mortality rate of just about 4.5%. The highest mortality rate of IRIS is with cryptococcal meningitis, because what you get is increasing inflammation in a fixed space in the skull. The skull can't swell. So if there's inflammatory response in there, the increase in the cranial pressure tends to be fatal, right? Which is, and we'll come to it later as to how we reduce the risk of IRIS with cryptococcal meningitis, and as well TB meningitis. And again, with tuberculosis, the mortality rate is 3.2%. A lot of that would be from disseminated disease, because in some cases of TB, it's not just in the lungs, it's everywhere. When you start them on antiretroviral medication, they get almost like a sepsis syndrome. There's fevers and nitrous, and their blood pressure drops, and they become septic. So that is thankfully not common. And I don't think I've seen a case in more than 10 years. Now, we spoke about some of the other causes earlier, but IRIS can occur with a lot of different clinical presentations, primarily based on where the primary infection is, and it can occur in response to a lot of different types of pathogens. So we spoke about TB, we spoke about cryptococcus, we spoke about CMV and Kaposi's, which is one of the viruses as well. But it can also occur In response to herpes simplex, we actually might be having a case downstairs. It can occur as with what we believe this case I presented with histoplasmosis, Mycobacterium leprae, leishmaniasis, non-mycobacterial TB, hepatitis B and hepatitis C, which are important because we have to monitor persons who start antiretroviral therapy who have hepatitis B to make sure they don't get a flare hepatitis and injury to their liver. And you can see all different locations where you can get evidence of iris in the brain, in the CNS, the eye, lymph nodes, skin, GI tract. It can happen anywhere. And it can sometimes be a sort of disseminated systemic inflammatory response syndrome, where you get just disseminated inflammatory response and disseminated intravascular coagulation and all sorts of things. Thankfully, that is rare. It can also occur unusually later on, not in response to disease, but just in the response of increased levels of inflammation, and it can manifest as a form of autoimmune disease. So it can manifest as a thyroiditis or Graves' disease sometimes. A lot of persons who develop Graves' disease, who live with HIV, it is as a manifestation of immune reconstitution syndrome, right? Sarcoidosis as well, lupus, Guillain-Barré, rheumatoid arthritis as well, it can happen. I haven't seen much in terms of those other diagnoses, but we have seen a lot of Graves' disease, right? It's not uncommon. So when we talk about iris, there are two main types. There's what we call paradoxical iris and what we call unmasking iris. And the way we differentiate between the two is the difference in time course between when antiretroviral therapy started and when the clinical deterioration takes place. So in paradoxical iris, what is the case is that someone with a known opportunistic infection, let's say they're diagnosed with tuberculosis, they start TB treatment, they wait a few weeks, and they improve, and then you start with an antiretroviral treatment, and because of the inflammatory response that occurs in response to the increase in CD4 count and drop in viral load, you get a paradoxical worsening. So you would expect that you start someone with advanced disease on antiretroviral treatment, they should improve. But instead of improving, they get worse. So in the case of TB, they will get more fever, more cough, they may get a pleural effusion, shortness of breath. They actually, lymph node will start to appear all over the place. And that's the paradoxical worsening, which gives this name to paradoxical iris. So essentially, the time course is the person diagnosed with opportunistic infection, then they start treatment, then they deteriorate after that in response to iris. With unmasking iris, it's different. The clinical manifestations of the infection are not there, so it's hidden. Because the person's immune system is so weak, they can't even mount an inflammatory response in the presence of whichever pathogen it is, right? So you start treatment with this silent infection, the immune system begins to improve, and then they deteriorate because now they get an inflammatory response to the pathogen that was always there, but now they're actually developing an inflammatory response to it. So that's called unmasking iris. And we see that sometimes with things like pneumocystis, that you start someone on treatment and 2 weeks' time they come with this dry cough and shortness of breath, chest x-rays are messed up. This is unmasking iris, it was there all along. But in both cases, what is necessary to make the diagnosis of iris is to exclude other causes of the person deteriorating clinically. So is this a new infection, right? Did they, let's say, come in contact with someone with tuberculosis and this is actually primary TB and not so much TB iris? Is this drug toxicity? If someone presents with a skin rash, fever, and hepatosplenomegaly and lymphadenopathy, this could actually be a drug reaction that we have to exclude. Or just the fact that we missed the opportunistic infection in the first place. So it's not a masking iris, it was just always there. And we didn't listen when the person said, I have a sclerotic week off and I have a little bit of night sweats. Or we didn't do the x-ray to show the TB cavity. So we're now seeing it as a masking iris, but it's actually paradoxical iris because we missed the diagnosis. So how does iris occur? So this is actually kind of a neat way of summarizing the factors that relate to it. So it's in response to what we call high antigen load, meaning that there are a lot of germs around for the immune system to kick up a fuss about, right? And that could happen in cases where there's disseminated infection. So the germs are all over the place. So when the immune system wakes back up, it has a lot of targets to trigger the inflammatory response. There's also, if there is a poor immune response in the first place, so that the immune system didn't respond in the first place, because that's in cryptococcal meningitis, you can get a lot of cryptococcus in your CNS and no white cells when you actually do the lumbar puncture, but you see the cryptococcal organisms there. It means the immune system hasn't done anything to this massive antigen. So when you actually do start antiviral therapy, you will get a rebound increase in inflammation in response to that. Low CD4 counts, as we said before, persons with low CD4 counts tend to be the persons who are at greatest risk of developing iris, because CD4 T cells are responsible for producing inflammatory cytokines, those cytokines that produce inflammatory effects and also recruit inflammatory cells. Also CD8 cells, we call it the killer cells, they do this as well. Now, one of the other factors that is thought to have a role in the pathogenesis of immune reconstitution syndrome is a dysfunction in regulation of the immune system, because we have both effector cells and suppressor cells, and they have to be in balance, otherwise the immune system will be like a runaway train. That the immune system is just attacking everything, and we're always sick, and we can't slow this train down. So there has to be a balance. And in early antiretroviral treatment, especially in persons who had profound immunosuppression, what tends to happen is that you get increased activity of the inflammatory type cells and less of an increase in the suppressor type cells. So you have a pro-inflammatory environment, which tends to produce more clinical evidence of inflammation. So that would lead to the symptoms of virus, some of which are systemic, so the fever, the night sweats, the anorexia, the constitutional symptoms we know about. And some of them are localized, like in this case where you just had it in one lymph node and nowhere else, apparently. So this was just a really nice radiological illustration of what iris looks like. So this is someone who actually had miliary TB, which is TB scattered throughout both lungs. It's not so clearly illustrated here, but you can just about see those little white flecks throughout both lungs. And a TB pericarditis, which is this heart shadow is enlarged. So this person actually started steroids, so prednisolone, for the pericarditis and anti-TB treatment. And in slide B on top, you see some of the white flecks are disappearing, the lung was clearer, the heart started to reduce in size. And but later on, when the actually steroids were reduced, you actually see this paradoxical worsening. So this person is on TB medication all this time. And you see this collection of fluid, which is this, just about see it here, this haziness on the left side, all this fluid building up in the lung that's not supposed to be there, and the heart's getting bigger again. So even though you've started the TB treatment, you get this paradoxical worsening, and then when you start back the steroids, everything gets back down to normal, and all as well. So this tends to be the sort of chronology we see in TB with iris. You start treatment at initial improvement, then a paradoxical worsening, and keep the treatment going as some anti-inflammatories, or on the case of a TB pericarditis, some steroids, and everything gets back on track. And the next question is, what do we do about iris once it's diagnosed? So the first step is to exclude either a new or an additional undiagnosed opportunistic infection, because persons who are extremely immunocompromised can have more than one thing. You know, usually there's this this maxim in medicine, Occam's razor. You know, you want to find, if you can explain something with as few options as possible, that's probably the best way to go. Not so much in someone who's immunocompromised. We've had people who've had pneumocystis and histoplasmosis, or histoplasmosis and tuberculosis. It's not uncommon in the most immunocompromised persons. So if someone comes with new signs and symptoms, always entertain the possibility that something is missing and be diligent in the search for it. What is sometimes a challenge in places like ours is that we don't have the same kind of broad lab support we would need to diagnose things. So for example, up until maybe a couple of years ago, we weren't able to test for histoplasmosis. We can't do TB cultures, we can't do MAC cultures, we can't do all these viral PCRs and those sort of thing, where because so many opportunistic infections look the same in terms of their symptoms, sometimes we just have to cast a broad net and see what we catch. A lot of times what we may wind up doing is ruling out the common things, and if we don't get a hit from things we can test for, treat empirically, and often for more than one thing at a time. So as I said, exclude no additional infections or malignancies or adverse drug reactions. Continue antiretroviral treatment unless the manifestations are life-threatening. And that is thankfully fairly uncommon. It is also recommended to continue the treatment of the infection or the malignancy and add anti-inflammatory treatment. Usually non-steroidals are enough. So that's like ibuprofen, diclofenac, those sorts of drugs, just to damp down the symptoms of the inflammatory response until the immune system gets back regulated and those that hyperinflammation goes away. In certain conditions, steroids are recommended. So for example, pneumocystis pneumonia with immunoconstitution syndrome and shortness of breath, you would give steroids. TB pericarditis, as we spoke about earlier. There is a potential role for some of the newer immunomodulatory agents. I'm stumbling, sorry. So for example, there's something called infliximab, which is a tumor necrosis factor monoclonal antibody that has been shown in a small case series to be beneficial. There was also a paper done 2018 where the investigators gave steroids before initiation of antiretroviral therapy in order to be ahead of time the inflammatory response that would have triggered iris on initiation of antiretroviral therapy. This was in persons with the lowest CD4 counts, and there was a statistically significant reduction in the incidence of iris in the cohort that received the prednisolone, and there was no, as you would worry about, increase in serious infections or cancers. So that was one potential additional use of steroids in the prevention of iris. It is not widely adopted, I don't think, primarily because the risk of a fatal outcome with TB is single digits percent. Plus, usually we can manage with non-steroidals. So to put someone on steroids ahead of time, not brought it up, at least not in Trinidad so far. So there are a couple of disease-specific considerations for antiretroviral therapy. So in terms of tuberculosis, the guidelines as to when to introduce antiretroviral therapy in someone who's being treated for TB have been coming down progressively over time. It used to be 8 to 12 weeks, then it was 8 weeks unless the CD4 was less than 50. Now it's 2 weeks across the board regardless of CD4 count. And this was in the most recent update of the treatment and care guidelines put out by WHO. And this is except in the case of TB meningitis. And TB meningitis, because of that risk of intracranial iris and good research evidence that there are poor outcomes if antiretroviral therapy is started too soon, the recommendation is to delay the start of treatment by about 4 weeks. And steroids do have a role in the management of TB meningitis, which is different from cryptococcal meningitis, in which steroids are not recommended because it has been shown to be of any benefit. And the WHO guidelines similarly, because again, that high mortality picture we saw, almost 1 in 5 persons with cryptococcal meningitis iris die from it. The WHO guidelines recommend that antiretroviral therapy be delayed by somewhere between 4 and 6 weeks. In histoplasmosis, thankfully, iris is usually not common. This is actually the first confirmed case I've seen of histoplasmosis iris, and we've seen a lot of cases over the time. Interestingly enough, there was another young man, and actually a couple others, who had the similar sort of presentation with this suppurative lymph node in their neck who tested down the line negative for tuberculosis, who in retrospect now, having seen this case, now if you have access to fungal testing, those may have been other cases of histoplasmosis iris that we missed because we couldn't detect it. But in histoplasmosis, the WHO guidelines are for immediate treatment in persons who are being treated for histoplasmosis unless there is a suggestion of CNS involvement. The guidelines don't speak in detail to how long to delay antiretroviral therapy for. I suspect it will be similar to the 4 to 6 weeks. And hepatitis B or C, we'll still try treatment immediately. But one of the things we have to monitor would be for flares of hepatitis activity related to iris. Severe hepatitis can occur and can be fatal. We had one such case. We've had a couple of cases of iris where the enzymes went up by about 4 or 5 times. This person went up by about 100 times. And he unfortunately died from massive fulminant hepatitis. Unfortunately, that was one case about 10 years ago, 8 or 10 years ago. In fact, we haven't seen another case like that since. So just a brief follow-up about our case. So we didn't give him any antibiotics or anything for the lesion. We just gave him diclofenac for pain and inflammation. We had tried to prevent the abscess from rupturing because that can sometimes lead to draining sinus for weeks. So we did multiple aspirations, but it still ruptured in the middle of the night. It has since closed up, and there's a minimal area of fluctuance still. And he's remained clinically well throughout. He's put on, actually came in today, he put on another 2.5 kilograms since it began in the early part of the month, sorry. We started on oral itraconazole. We chose oral treatment as opposed to IV amphotericin because clinically he's well. This is clinically very mild disease. So it doesn't seem to warrant hospitalization and treatment with amphotericin. Because of the interaction between itraconazole and efavirenz, which is what he's on right now, we had to switch his regimen to atazanavir, ritonavir, and Mrftt to tenofovir. And he's scheduled to follow up in a month, but so far he's doing really, really well. So just in summary, immune reconstitution syndrome is a common cause of morbidity in persons living with HIV with advanced disease in particular. Diagnosing iris is often an exercise in excluding other conditions, and management usually consists of continuing antiretroviral and opportunistic infection medications, along with anti-inflammatory treatment and management of local complications. And that's the end of my presentation. Thank you so much for your attention. And open the floor for questions if there are any.
Very good. That was very good.
It was a really interesting case.
Yes, it was. It was.
This is actually the first case I've ever seen of histoplasmosis iris, even though we've seen so many cases. So,
now you know what to look for.
Exactly, because as soon as I saw this guy and realized it was histoplasmosis, there were at least 2 or 3 other cases I know of that had an identical presentation. It wasn't TB, and we couldn't figure out what it was.
Yeah.
So the penny drops. So now we know.
Great presentation. Thank you.
So open the floor.
I'm going to get off this call at this time because I see some of my people walking in front of me trying to get my attention.
I got you.
So let's go see what they need. And thank you so much for having me on the call again. I hope moving forward I won't be as swamped and be able to join you guys again. So
that's okay. We appreciate your presence. Have a great day.
Take care. Thanks.
Okay. All right. So again, we're a small crowd here, a small room. If any questions, any comments, let me know. If not, we may have an early end today. The one thing that I think was good with this moving forward is that we do have a liposomal amphotericin B now, which is a much better version of the drug. Higher doses, less toxic. So a lot of times when we have suspect cases of histoplasmosis, because we're so afraid of amphotericin B, which we would almost be afraid to risk trying because of the toxicity. But now I think we can have a slightly freer hand because it's really not as toxic as the older version. All right. So if there are no other questions or comments, I think I will close up a little early today because we're busy downstairs, so I have to rush back downstairs to support the team. So again, thank you, everyone. Thank you, Jennifer. Thank you, Jacqueline. Good to see you. And yes, I got the thing from ComTalk, so I'm sending as many patients as possible to that entrepreneurship development session, and we'll put it on our staff chat if they have patients who can benefit from it. I think that's one of the things you really need to start doing, is empowering our patients to earn a living on their own and come off sometimes state support for years, because it feels so disempowered. So that's a really, really great thing you guys are doing. I very much appreciate it. Okay, so that's it for us.
Yes. Thank you for this session. I really appreciate that.
All right, thanks so much. All right, so we're off for the time being. Take care and be safe.